Thank you so much, Dr. Abdullah, for the kind invitation. I'm glad to be here with my senior colleagues from around the globe, and I'll try to cover this topic, which actually deserves an entire conference on its own, the cardiorenal interactions. So I'll try to cover in the coming 15 minutes what's very pertinent to the practicing physician, of course, with a theoretical background on why we do things the way we do. So I'll be talking about the epidemiology, the pathophysiologic interactions, why is the glomerulus important, and the tubules, why are they important, and then, of course, the impact of heart failure therapies, RAS blockers, SGLT2 inhibitors, diuretics, MRAs, and of course, the potassium binders. Why is chronic kidney disease important? Number one, it's very prevalent in patients with heart failure. Between 30 and 60% of heart failure patients tend to have some form of chronic kidney disease, depending on the cutoff of chronic kidney disease, perhaps because they share common pathophysiologic reasons, hypertension, diabetes, atherosclerosis, drugs, etc. And we also know that the presence of chronic kidney disease means that the mortality will be higher, whether we're talking about systolic heart failure or diastolic heart failure. The mere presence of chronic kidney disease results in a 70% increase of mortality in HFpEF and a 30% increase of mortality in heart failure with reduced ejection fraction. And their interactions between the heart and the kidney are extensive and intricate and complex. They involve at least hormones, neurons, hemodynamics, and molecular signals, cellular pathways, etc. But if we take just the most commonly, the most studied pathway, which is the sympathetic, renin, angiotensin, adrenal axis, we see that the interactions between the heart, the brain, and the kidneys, and it's always a positive feedback. That's why it's a vicious perpetuating circuit, where sympathetic activation results in renin release, angiotensin activation, which in turn activates the sympathetic nervous system, and that's why we see heart failure patients always going down in a spiral circuit. So this is my own understanding that the interactions are hormones, neurons, hemodynamics, and drugs, and they are always self-perpetuating between the heart and the kidney. And central to our understanding of the cardiorenal interaction is understanding of the glomerulus, because it's the functional unit of the kidney. It has an afferent arteriole that brings the flow, and an efferent arteriole that takes away the waste products down to the collecting ducts and urine. And it's important to understand that constriction of the afferent arteriole and changes in the vasotone of the efferent arteriole, they affect the filtration of the kidney. One of the compensatory mechanisms, it's a compensation that our bodies try to do, because the kidney understands heart failure as a state of hypoperfusion. So the kidneys, as a part of sympathetic and adrenal release, it tends to constrict the efferent arteriole. And this tries to keep the filtrate in the glomerulus and preserve the kidney functions in the face of reduced renal blood flow. And unfortunately, that's one of the most important agents, which is the RAS blockers, tend to abolish this compensatory mechanism because they tend to vasodilate the efferent arteriole. So there is a form of shunting phenomenon, and this explains why when we start RAS blockers, there is a tendency for a transient or a temporary decline in kidney functions because of this blocked vasoconstriction of the efferent arteriole. But fortunately, our compensatory mechanisms, some of them are beneficial. We have the neprilysin and the natriuretic peptide system that tend to counteract the renin-angiotensin system. They are vasodilatory, they are antifibrotic, they blunt the sympathetic flow, and they also work on the kidney because they also tend to vasoconstrict the efferent arteriole. So when we combine RAS blockers with neprilysin inhibitors, that's why we start to see some improvement in kidney function. And of course, this curve is no surprise. Patients with chronic kidney disease, this is the paradigm trial. Patients with chronic kidney disease tend to have higher risk, whether they're treated or they are with placebo or with ARNI. But you see that the benefit that we get is still bigger in these population of patients. And the paradigm, this is a subgroup analysis on kidney outcomes. It was for the first time in heart failure that we see that an agent for heart failure is able to preserve or slow down the decline of kidney function. We didn't see that with beta blockers. We didn't see that with MRAs. We didn't see that clearly with ACE inhibitors. But it's probably the combination of the RAS blocker and the neprilysin inhibitor that we started to see a beneficial effect from ARNI on kidney functions. We see that the decline in kidney functions, which is very rapid in heart failure patients, has been slowed down a bit by ARNIs. And we've seen the same phenomenon not only in heart failure with reduced ejection fraction paradigm, but we also saw it in heart failure with preserved ejection fraction. The slope, the decline, the speed of decline, the downhill course of chronic kidney disease patients is flattened when we give them ARNI, whether it is heart failure with reduced ejection fraction or preserved ejection fraction. And the percentage of patients who deteriorate their kidney functions more than 50% is significantly reduced when we give them the RAS blockers. So how can we balance things? We need to give them something that protects the heart and the kidney, but we're worried about some decline in kidney function. And there's a very nice document from the European Society of Cardiology on this topic. We need to accept some increase in serum creatinine, of course less than 3, and we can expect some decline in eGFR within 25 mL per minute. We need to reduce the diuretic dose if we can. We need to stop any offending drugs, nephrotoxic antibiotics, non-steroidal anti-inflammatory. We need to be sure that this transient change in eGFR is completely reversible. So if for any reason you stop the medication, then the kidney functions will return if you need to do that. So we've talked about the glomerulus, which is the functional unit. Now we talk about the tubules. And why are they important? Because at least 4 of the heart failure medications work somewhere along this microscopic histology. We have the SGLT2 inhibitors, which work in the proximal convoluted tubules, loop diuretics in the thick ascending limb of loop of Henle, thiazide diuretics in the other part of loop of Henle, MRAs in the distal collecting duct. And as we've seen for the first time with the paradigm in 2014, we saw that a cardiac medication is able to preserve the kidney. And we saw some effect. There was less than 1 point change in the slope. But looking at the SGLT2 inhibitors, they seem to be targeting more. We don't know the exact mechanism, but they seem to be working more because the slope of decline, the difference is 1.7 mLs. With ARNI, we had just like 1 mL. So they seem to be working in a better way. But please focus on the initial decline. Whenever we start these medications, we expect some decline in eGFR, the same that we saw with ARNI. But again, if we are looking for the future, then we need to continue these medications. We've seen that with reduced ejection fraction, and again, we've seen the same slope, the same protection, the same flattening of the downhill course with empagliflozin and the Emperor Preserve. So whether it's HFrEF or HFpEF, these agents seem to protect the kidney. And we've seen also the same with the other competitor, IMPA and DAPA. We've seen that in the DAPA-HF. Again, the percentage of patients who ended up declining the kidney functions more than 50% were significantly less in the DAPA-HF trial. And the same phenomenon, the slope tends to be flattened after an initial decline that we see. So whenever you see this decline, accept it, don't panic, and continue the medication, because on the long term, these medications will protect the kidney. And this is, again, one of the excellent papers that I would recommend you to go through, published by the ESC recently, in the beginning of this year, looking at the interaction between renin medications. It's a very nice document. I would like to congratulate the authors for this. And you see the common pattern of RAS blockers, SGLT2 inhibitors, that whenever we start them, we see some initial risk and initial hazard. There's some decline in eGFR, but as we go on, the downhill course of the chronic kidney disease progression is tamed down by combining RAS blockers and SGLT2 inhibitors. This is one very practical algorithm that tells you what to do when you have a patient with chronic kidney disease and you need to start heart failure medications. Of course, if the eGFR is more than 660 or more, then you can start the 4 therapies and there shouldn't be issues. But when we are between 30 and 60, then you need to think. Of course, 3 of them can be used, the SGLT2 inhibitors, the beta blockers, and the ACE inhibitors cautiously. The one that you need to think before prescribing here is the MRA. You need to check that the potassium is less than 5, the systolic blood pressure is okay, and the eGFR is more than 30. As the eGFR goes down, then we tend to lose the efficacy of some agents, maybe ACE inhibitors, RNA are still there, SGLT2 inhibitors still there, beta blockers are still there. Once the EGFR goes below 15, then we are limited in our choices only to beta blockers and maybe hydralazine nitrate. And of course, we titrate unless there is an increase in serum creatine that's more than 50% or increase of potassium more than 5.5. And one of the common pitfalls that I see in practice is that I see physicians tending to go very gentle on diuretics in patients who come with acutely decompensated heart failure, especially if they are edematous. And this is one excellent document. It's been published by the ASC back in 2019. It gives practical guidance on how to use diuretics for someone who's acutely decompensated with heart failure. And you need to start with double the oral dose, and you give that in an IV format. And you need to target a very good urine output. Your target urine output in the first 6 hours is 100 to 150 mLs per hour. And honestly, I don't see many people adopting the same practice. By the end of the first day, which is the other side of the screen, if the patient has already passed 3 or 4 liters of urine, then you can feel comfortable. If not, then you think of escalating with other diuretics. And why are people intimidated by proper use of diuretics? Because they are afraid of worsening kidney function. But we tend to forget that the strongest determinant of worsening kidney functions is not the use of diuretics, it's the central venous pressure. So whenever the patient is congested, these patients have the highest risk of getting some worsening of renal function. It doesn't matter their blood pressure, but the central venous pressure is the strongest determinant. And the next slide is going to be a bit of surprise, because what we were designed to think is that whenever there's worsening of kidney function, then the outcome is worse. Whenever kidney functions improve, then the outcome is better. But if you look at this group from the DOSE trial, which is the most famous trial on diuretics, to the left side, these are the patients that improved their EGFR. And you see that there is a paradoxical phenomenon. Their mortality tends to increase. Whereas the patients that we worry about, whose kidney functions worsen, there is no change in mortality. So again, this is from the biggest trial on diuretic therapy, the DOSE trial. So when you give the patient a diuretic and you see some rise in serum creatinine, please don't worry. It will not change the outcome. Maybe you should get worried if the serum creatinine tends to improve. And because we are getting into more diuretics and more MRAs, focusing more on the kidney, there is a new agent that is coming at the step door of heart failure. Didn't go into heart failure yet, which is finerenone. Finerenone is a mineralocorticoid receptor antagonist, but it's different from spironolactone. It's a non-steroidal. The chances of hyperkalemia are less. It has not been tested yet in a stage 3 trial of heart failure, but it seems to work in patients who have chronic kidney disease, not only on the kidney, but it prevents heart failure hospitalization, even when it's given to someone who has heart failure, who's asymptomatic, or didn't develop heart failure. So probably these agents are coming on the horizon. And because we go into MRAs, beta blockers, and RAS blockers, we need to think that what these agents share is that the risk of hyperkalemia. And for some reason, our bodies, our physiology is dependent on a very narrow range of serum potassium, which is actually between 4 and 5. Whenever we go below 4, the mortality rises. Whenever we go above 5, also the mortality rises. That's why the ESC decided to take the cutoff of hyperkalemia as 5, not as 5.5 as we studied in the medical school. And we know that as the serum potassium rises from 5, 5.5, 6, then the adverse outcomes at the heart and the kidney tend to increase. And because we're used to seeing acute rise of potassium in the ICU, so we think that it's an acute process, an acute event, and once it's done, then the patient is safe. But unfortunately, they tend to recur. And they tend to recur not once, but 3 or 4 times in the first year of the patient's life. So once the patient gets hyperkalemia, expect that he will get hyperkalemia further. And of course, the patients who are most likely are those with heart failure and chronic kidney disease. The guidelines tell us to stop MRAs whenever the potassium exceeds 5, RAS blockers whenever the potassium is 5.5, and we do that and we feel safe. But what happens actually is that once we reduce the doses of RAS blockers, we tend to go home, feel that we did the right thing. We think that we abolished the hyperkalemia, whereas in fact, the mortality of heart failure tends to increase as we cut on the doses of RAS blockers. We've seen that with RAS blockers, and we've seen that also with MRAs. Whenever we reduce the therapies or stop them in a patient with heart failure, there's a strong tendency to relapse. So what do we do when we give a patient a RAS blocker? He has some chronic kidney disease. Okay, we tolerate this transient rise in serum creatinine, but how can we tolerate the hyperkalemia? It can be lethal. And the tools that we have in our hand until recently were very limited. We stop the RAS blockers. We see that it's dangerous. We give them a low potassium diet, which is a deprivation of the most Mediterranean diet and the beneficial effects on cardiovascular outcomes. The potassium binders that we had early, they are very limited because they tend to have GI toxicity, so they are not recommended to continue on the long term. And now we have two agents. They are like empagliflozin and dapagliflozin. We have the patiromer and the sodium zirconium, and they both have good effects. I had the chance to use only one of them, which was the patiromer, and once we start these medications, then we become more flexible in up-titrating RAS blockers and MRAs and beta blockers as well. They're still not into the guidelines because they will not demonstrate, unlikely to demonstrate a mortality benefit, but these are enabling agents that allow you to continue MRAs and to continue RAS blockers. And probably the latest piece of evidence and the biggest evidence that we had is in the Diamond trial. This is the design of the trial. That the trial was released in the latest ACC, which was in April. It's not published yet. The trial looked at a group of heart failure patients, more than 800 patients, whether they had hyperkalemia or not. And those who had hyperkalemia were randomized to patiromer or placebo. And they followed them up. And as I told, it was released as one of the late-breaking clinical trials in the ACC by Dr. Butler. And these are the findings. The change in the serum potassium with patiromer was 0.003, and with placebo it was 0.13. So as a clinician, you would think, who cares about this? They are both very trivial differences. Why should I care about an expensive medication for someone with hyperkalemia? But I would like to alert you that the placebo group, they all stopped the MRAs and the RAS blocker, whereas the patiromer, mostly 85% of them continued RAS blockers and MRAs. So if you continue RAS blockers and MRAs and you give patiromer, the chances of rise of serum potassium are much less compared to stopping MRA and RAS blockers. So these agents are probably going to have a good future. So we reviewed the epidemiology, the pathophysiologic interactions of hormones, neurons, hemodynamics, and drugs. You understood the afferent arteriole, the efferent arteriole, where every agent works in the tubule, and we've seen the protective effect of ARNI after an initial decline. The same with SGLT2 inhibitors in HFrEF and HFpEF. How strong should be used diuretics, and don't worry about kidney function. Thank you so much.
Excellent.